and fellows in our conference room as well. So we'll go ahead and get started with our grand rounds for today. It's my privilege and pleasure to introduce Dr. Jonathan Menachem as our speaker, and want to also thank Arthi for who suggested him as our speaker today. So a little about Dr. Menachem. He completed medical school training at Tulane, and after that, completed internal medicine residency at Duke, which I just found out was co-resident with Mendar. So maybe you can tell us all about Mendar's younger days. But anyway, after internal medicine residency, completed cardiology fellowship at Penn, and after that, pursued not just one, but two additional subspecialty trainings in both heart failure and transplant and adult congenital heart disease at UPenn, really carving out an area of expertise for himself. And after completing his training, he joined faculty at Vanderbilt, where he's currently the associate professor in the departments of medicine and pediatrics, and also the director of the Advanced Congenital Cardiac Therapies and associated director of heart transplantation, and has really grown the adult congenital heart transplant program at Vanderbilt and turned it into a national referral center. With his background expertise, he's really the world's expert in adult congenital disease heart transplant and has written extensively in this area, in this subject, and is a frequently requested lecturer. So it's again my pleasure and privilege to hear him talk to us today about advanced therapies for congenital heart disease patients. Thank you, Dr. Menachem.
Yeah, thank you for having me. I'm looking forward to this. I would ask, it's always kind of a bummer to not be able to do these in person. So if people want to turn on their video, I would love that so I can see some faces at least and feel like I'm there. I think what you will see after this talk is that I appreciate it was very nice of you to say that I'm an expert on this, but I think what you will quickly see is that none of us are really experts on this, and we're trying our best as a team to figure out how to best treat these patients. Disclosures. Just to give you a little bit background, a little bit more info as to how someone winds up doing what I'm doing. So I grew up as a kid in New York City. I was a Duke undergrad, and I decided I was going to do investment banking with my life. And after a few years of doing that, I I decided that I wanted to go to medical school. And so in the meantime, I worked for Fox Hollow Technologies, which was a medical device company, atherectomy catheter that's centered in Redwood City. And then while I was there and while I was planning on going to med school, I read this amazing book called A Walk on Water, which is all about congenital heart surgery that was performed at Cleveland Clinic by Roger Mee, and all about the switch from going to the arterial switch from an atrial level switch from the mustards and sendings to the arterial switch, and how that impacted all of the kids and now adults. And so I went to Tulane right after Katrina, and there I did my pediatric rotation at Ochsner, where it was the only place in the state that had an adult congenital program. So from there, they suggested that I spend some time with Wendy Book at Emory. So if any of you know her, she's one of the smartest, most amazing people of all time. But she had done training in both congenital heart and transplant. I did my residency at Duke, which is unfortunately for Mandar, where he had to interact with me. And then at Duke was where I got interested in transplant. I knew I was going to do congenital heart, but I got very interested in transplant. So I was fortunate to have mentors on both sides that pushed me to suggest that I go to Penn, which was where I could do focus on both things for fellowship. And then at Penn, I wasn't really sure how I was going to do all this, but it was nice that Mariel Jessup was my mentor at Penn, and she told me, don't be a congenital person that knows about transplant, be a transplant person that does congenital, because there's not many people that are doing that. And so from there, she recommended that I work for Joanne Lindenfeld here at Vanderbilt, who's been by far one of the best mentors you could possibly have. And Joanne is brought me in to focus on transplant and mechanical support in congenital patients. So here's the outline for what we're going to talk about. And I'd just like to I start all these talks with a little bit of congenital heart history, because if you look at what Osler said about it back in 1892, he essentially gave it 4 pages and said there's nothing to do for these patients and that they all end up dying. What you know now is that that's actually not the case. There's 20,000 new patients that are coming to adult clinics every year with congenital heart disease. It's the fastest growing segment of adult cardiology. And beyond that, there's actually more adults with congenital heart disease right now than there are pediatric congenital heart patients. So this is a fast and a rapidly growing segment of patients that need treatments. Because of all the amazing care that they've gotten for all these years, now we're finding that all of these patients, the number one cause of death in them is heart failure, and not enough was being done to take care of them. You know, you see this graph that was done. This is old data, but it looks like, these patients are getting transplanted and it's growing. But if you look at the proportion on the left-hand side, you recognize that there's not many of these patients that were undergoing transplant or VAD. So when I came to Vanderbilt, Joanne said, we got to focus on this, on using what you've studied and how you've done it to grow this program. So between 2012 and 2017, only 2 adults with congenital heart disease had undergone transplant. So we said, well, this is not okay. We got to change this. And I sat down with Joanne and she said, all right, we're going to make the goals very simple. Our number one goal is we're going to figure out how to find the patients, which we thought was going to be difficult. Then we're going to grow our research efforts, which I was pretty much opposed to at first because I'm not a research person. But Joanne was insistent on it for 2 reasons. One, if you want people to listen to what you have to say, you got to prove it. And the second thing was, she said, it's the best way we can possibly have to build teams and collaborate with centers around the country. And then lastly, we were going to figure out how to improve patient care. So turns out that finding the patients was the easy part. We thought it was going to be hard. I thought everyone was going to come from Tennessee, and what I'll show you now is the patients are coming from around the country. Last year, we did about 500 transplant evaluations for our entire program, and about 1/3 of those are adults with congenital heart disease. So if you build it, they come. Sometimes too late, which is going to be one of the things we're going to talk about here. And then, okay, so we're going to improve care as the next project. So this is going to be pretty easy. So one thing we're going to go with is we're not going to believe what we've been told in terms of the hype about outcomes, because this was a paper that Gabe Hernandez published with us, that a lot of this was based on, outcomes are bad in the Fontans. And if you look, this is NIS data, which is not perfect, but most of the patients that are dying after transplant are Fontans. And so that's why outcomes look so bad. The second thing we knew from data that we looked at from UNOS was that patients that are transplanted at high volume centers, so any center that's doing more than 14 transplants, has a better outcome. Now, this is not congenital transplants, this is all comers, so all number of transplants. So we've got this covered, right? We're not just going to believe that Fontans are everybody. We have a big center. And then, of course, we also know that if in centers that have big ACHD programs, their outcomes with transplant are better. So we had all 3 things, and we were wrong. So right off the start, first congenital patient, heart, liver, he died. And I will tell you that we learned a lot from James. James is probably one of the most important people in the growth of this program. One of the things we quickly learned was sometimes patients are just too sick and you have to be able to say no. We also recognize that doing a combined heart-liver operation is not just doing a heart operation and a liver operation. The planning has to be impeccable. Everyone's got to be organized and talk together. And then we also had to recognize, and this was really a positive thing for our entire team, was when we spoke to his mom, she told us that even if we had told them that they had very little chance of survival, they would have taken that chance. And so the things that we took a lot that we learned from James and said, okay, we got to get patients sooner, and we got to be precise in the way in which we evaluate them and move forward with transplanting them. And then on top of that, we got to be okay with the fact that not everybody's going to survive, but the patients understand that, the families understand that, and they are willing to take risks. So how do we identify the risks? So one of the things that we started off by doing is saying, okay, not everybody is created equal. And we looked at all of the patients and said, who are the highest risk and who are the lowest risk? And what you'll see is on the left are the systemic left ventricle patients that are two ventricle patients are on the lower risk spectrum, like tetralogy of Fallot. Then the systemic right ventricle patients become a little higher risk, and then of course the Fontans. So we're going to start grouping patients by anatomy, and then we're also going to group patients by what their associated symptoms are and complication risks are. So, we see a lot of patients, right, for transplant that have elevated atrial pressures and are sensitized. So are these high risks or low risk features? Or we have patients that have pulmonary hypertension and then have protein losing enteropathy. So we're going to weigh all of these possibilities as we think about who we can transplant. At the time we did this paper, we hadn't thought about this other group, which I will talk to you more about, the Shohn's patients who, every congenital person will tell you they have a favorite lesion, which for me is L transposition, and least favorite lesion is Shohn's, just because I find these patients so high risk and so difficult to deal with. But part of the thing that was also really important was, in terms of not sending someone in too sick, was to say, let's get patients early enough. There's this common statement that's used in ACHD meetings around the country all the time that, oh, well, they fell off a cliff. So I'm going to quote one of my favorite movies. Mandar knows this from residency, that I oftentimes talk in movie quotes. So if you don't know these, I apologize. But this was the movie Fletch. And there's this interaction between Fletch and this doctor where the doctor says, it's a shame about Ed. And Fletch says, well, yeah, it was a shame for him to go so suddenly. And the doctor says, well, yeah, but he was dying for years. Fletch says, yeah, but the end was very sudden. And the doctor says, but he was in intensive care for 8 weeks. He says, yeah, but I mean the very end, when he actually died, that was really sudden. So these patients, by definition, fall off a cliff, because all patients fall off a cliff, right? But the question is how far away is the edge and how fast are we moving towards it? And that's one of the things we've tried to focus on, is preventing the abrupt fall that we're not ready for. So we used a lot of that in our next patient that was a heart liver. This is Sean, who's now about 7 years out from heart liver. He's also kind of a whack job. So he celebrated his 30th birthday with this disgusting cake of a heart and liver. But he did get to celebrate with his son, Mason. And Sean not only survived and was only in the hospital for about a month, but we used less than 10 units of PAC cells for his transplant, which is a completely different phenotype than we had done with James. So how do we prevent this fall? We got to understand the patient's symptoms, and this has been hard for us, just as a general group of congenital patient providers, but we use peak VO2 and we use CPET a lot. And what this data showed out of Boston was that it's not necessarily the number, the peak VO2, it's the change in the peak VO2. And so we put these patients on the treadmill frequently, sometimes every six months, to see if we can pick off when they're falling. Because what we know from this data that I published, this was when I was a fellow at Penn, but these were 20 patients that had been transplanted. And if you look at the peak VO2, you'll see that only one of the 20 actually met the thresholds that we usually talk about for transplanting congenital patients, right? We usually talk about peak VO2 of 14 or 12 when they're on beta blockers. So what we look at is, for CPET, is we look at changes. We look at time on the treadmill, because I think that tells a lot. We look at percent predicted for age. So it's a combination of all of these things, because we also need to understand symptoms. What I'll tell you is, these patients can do terrible on a treadmill, but they don't really understand how they're actually feeling, because they've lived life just adjusting. So this was Elizabeth Barnett, who was one of our patients that came to us from uh, Louisiana, and her goal was just to be able to dance like a weird lady and a maniac at a concert, and wanted to be able to climb 380 stairs. And when we talked to her a little bit more about this, and one of the reasons we used her from an education standpoint was she told us that one of the best parts about transplant was after transplant, she was able to go trick or treating because she had never done that before because she was always too short of breath. And I mean, I have a 7-year-old boy, so sometimes that's a high intense sport, but for the most part, trick or treating is not a very intense exercise that people should not be able to do. We think about arrhythmias a lot, and I won't go into all of this, but we've had a lot of these patients, especially the Fontans, develop VT and SVT, and this is the white flag in a lot of these patients that if we start to see more arrhythmias, we need to pay very close attention um, to the fact that they need to be transplanted. We talked a little bit more. I was meeting with some of the heart failure folks before this talk about, part of the problem has been in terms of getting patients to transplant. A lot of times centers have turned these patients down. And so they will try to do all sorts of things in order to get them safely to transplant or try to prolong their life. And one of the things we're trying to convince people to do is if you're thinking about transplant, just refer them because everything we do can impact the patient's life. This was a patient who was a systemic right ventricle patient and a mustard who had their SVC limb stented, which got the guy about 6 months of feeling better before he started feeling worse again. And the reason I show you this is because at the time of transplant, he almost had a catastrophic bleed because when they removed the leads, it ripped his SVC. So he was very lucky that he survived. And we tell people, I'm not telling you not to put in a stent, but let's consider how everything we do to these patients impacts them. We do check a lot of labs. High sensitivity CRP has been shown to be a marker for worsening, as has MELD-XI, which really shouldn't surprise anybody, right? So the patients, as their liver gets worse and their kidneys get worse, their risk for worsening goes up. Protein-losing enteropathy, which I won't spend a huge amount of time on, but this is a very morbid condition that congenital providers deal with on a regular basis. In the Fontans, they develop channels where they lose their protein through their gut, and as a result, they develop ascites and pleural effusion because they're very low albumin levels. They're at high risk for infection, and they also are malnourished. Protein-losing enteropathy is actually one indication for transplant, and in the kids, they do pretty well after transplant for PLE. This was published by Kurt Schumacher, who has done some excellent research in congenital heart disease. The problem is, though, is that, as you know, there's a big difference between an 8-year-old kiddo and a 40-year-old Fontan. And so we were finding that protein-losing enteropathy was having a bigger impact. So we wanted to figure out how we're going to best treat this. And Wendy Book had been doing this for years, so we got her to do a study with us where we put these patients on midodrine. The team in Michigan had put people on dopamine, which works really well to control protein-losing enteropathy by causing increased it works a number of different ways. We think it works by increasing blood pressure, impacting the lymphatic channels, and also causing splanchnic vasoconstriction. The problem is, as you know, is dopamine has to be in an IV and PICC lines and all that thing. So Wendy started putting all these patients on midodrine, and what we're finding is in a number of these patients, we were able to get them off the transplant list because their PLE went away. There's also a number of the patients that we know they're going to wind up needing transplant, but we've been able to put them on midodrine, and in a number of cases, their ascites improves, their albumin improves, so they're a better candidate going into transplant. Because, yes, we can do this, but it's way better to take a person in for transplant that has an albumin of 4 than it is of 1.8. We had a patient recently that we transplanted that had a low albumin. We could not get his albumin up. His PLE was so bad. He did really well with transplant, but has come in twice now since transplant with infections. We try to treat also is this, and this is where the heart failure part comes from my side, is let's just treat at least all the two ventricle patients like they have heart failure, and let's use all the meds we have. And so it should be no surprise to anybody that Entresto works really well in systemic right ventricle patients. This was a small study that was done, showed increased improvement in 6-minute walk. And interestingly, you saw an increase improvement in cognitive function and sleep, which I think is due to the fact that it probably caused decreased pulmonary edema and increased blood flow to the brain. I can't prove that, but I will tell you that we're doing this on all of our patients, and we've actually turned down being involved in randomized trials to put patients on Entresto because all of our patients are getting started on it. And the next thing that we're doing also is SGLT2s until we can show that it's a bad idea. We're not doing Entresto in all the Fontans for a variety of different reasons, but we are trying it in our systemic right ventricle patients and the two ventricle patients. We've done CardioMEMS. We've done it a few times. This was started, the Ohio State group was doing this a lot. And it's, I mean, no surprise, right? It's keeping patients out of the hospital. I'm going to tell you a little bit now about some research stuff. Part of the reason I tell people that I'm from New York is that is because that's where my ability to argue comes from, I think. And so my research is based in the fact that I don't like myths and I don't like people saying things that we don't know are true. So I defined all my research as pretty much based on ACHD myths. So let me just define that for you. These are statements that are based upon what's previously been done. So they're anecdotal. To be a true myth, it's not based on any data. You say it loudly and definitively from a podium, and then you get off the podium before anyone can question what you've said. But all in all, a lot of these decisions and statements that have been made they just lead to fewer transplants and longer wait times. So let me show you I'm going to show you 8 myths that we're sort of working to disprove or at least discuss in terms of how to better care for these patients. So one is this idea that, these patients all have pulmonary hypertension. They all need a combined heart lung. And I think it's really great how you guys have in your heart failure group is pulmonary hypertension is involved. That's not the same everywhere. But for a long time, there was this idea that all of these patients have elevated left-sided pressures and they have elevated right-sided pressures. And so they have pulmonary hypertension and they need a combined heart lung. And this was a patient who was at Penn who came in. And if you look at the initial presentation, you'll see, right, elevated filling pressures, low cardiac output, and a PVR of 13. This patient was discussed initially for a combined heart lung. But if you look at it from a non-ACHD, pretend this is not a congenital patient, everyone would say, patient's really low output and they're filled with fluid. We don't know what the PVR really is. Let's decongest them, give them some forward flow, and see what happens. And what you'll see is that on day 37, with nipride and dobutamine, now you've improved cardiac output. The PVR is normal. This patient did, or not normal, but it's acceptable. This patient did well with transplant and did not need any pulmonary vasodilators afterwards. Now, the question you may ask is, why not VAD that patient? Why would you keep someone in an ICU on dobutamine and nipride for so long? And the answer is, there was no surgical interest in VADing this patient. But we had a similar patient when I got here to Vanderbilt who we did just that. This was the first time a HeartMate 3 was used in these patients. This was Miss Hodge, who came in pretty much almost the exact same presentation. We VADed her, and now she's about 5 years out from transplant. I don't know if you guys are seeing this, but we are seeing a new amount of transplant patients getting humongous tattoos celebrating transplant. I think some of this has to do with the fact that since we're giving them Hep C hearts, they're no longer scared of bloodstream infections. So We're seeing a lot of this. But she's now about 5 years out, and then we were able to do the same thing with this patient, Mr. Cochran, who had been stuck in a hospital for about 4 months waiting on a transplant. We've added him, and then he's now about 2 years out from transplant. The number two thing is that Shone's is not easy. I think Shone's is one of the hardest things to deal with because everybody thinks about Shone's as it's just valve disease. But what it ends up being is it ends up, if you wait too long, it's valve disease plus everything else. This was a patient who had repeat mitral valve surgery in a way that they had, and you can see here on this scan, that had a conduit placed, a chimney graft up into the left atrium with a valve placed in it, which not only did the valve get all calcified, but the conduit, the chimney graft occluded two of the pulmonary veins. Long and short of it is really bad pulmonary pressure. So this patient had to undergo transplant and was kept on ECMO for 2 weeks to make sure that we didn't wind up with acute right-sided failure. And she's now done quite well. But I think some of this could have been avoided if we had paid attention to the fact that Shone's is not just valve disease. And I just showed this picture. This is where they took off the roof of the atrium. You see that the valve is right there. Honestly, I think Shone's is the worst. This is another patient that we had who had true bad pulmonary hypertension, came to us from California. He needed a heart liver, was in the hospital on high dose pulmonary vasodilators and persistently needing IV diuretics. So he was transplanted with a combined heart liver. Interestingly, he got engaged on his last day in the hospital and he just had a baby. But Shone's is really complicated. Our Shone's patients have, when I look at all of them, one of them did not survive and make it out of the ICU. One of them needed a heart kidney. One of them wound up on ECMO. He wound up with a heart liver. So this is a high risk group. And one of our fellows, who's now well, she's not a fellow now. She's an attending at Temple. Liana Labrada who's working with Paul Forfia, is publishing our experience on Shone's with us, Stanford, and Duke, to talk about how pulmonary hypertension affects these patients. And interestingly, I was on the ACHD guidelines where there wasn't much about mitral valve stenosis and Shone's complex, and we have just added an additional recommendation that these patients undergo hemodynamic monitoring periodically to prevent the need for dual organ transplant. The third thing is, and I won't bore you with all of the details, but this idea that all these patients need bigger hearts because the RV is at risk for failing. And Dan Clark, was one of our fellows that's now down at Stanford by you guys, looked at this data in UNOS and said, okay, we know that we shouldn't undersize hearts, but do we need to put big hearts in all of these patients for the perception of pulmonary hypertension and RV risk of failure? And so he looked at height, weight, BMI, LV mass, and predicted heart mass. And it turns out that there was no benefit in oversizing donors. Do we do it sometimes? Yes, but we shouldn't necessarily wait because we're just increasing the time that patients are waiting on transplant. There's a myth that these patients need extra parts. So let me explain to you, or try to explain to you with this drawing. So at the time of transplant, this is now the donor. The donor the heart is transected and the heart comes back to us and goes to a recipient. What you'll see here is, though, for the Fontans, right, the Fontan patients have had a lot of work on their pulmonary arteries. So there's this thought that, okay, what we're going to do is we need to be able to get all of the pulmonary artery out to the hilum. So we're going to so what that essentially means is we have to wait on a donor where the lungs are not being used. So this would be like, for those of you that are not transplant people, you would see this in someone that has ARDS or a COPD patient where we're able to use the heart, but the lungs are not going to be used. And this does make the operation simpler because they don't have to redo any of their pulmonary arteries. Problem is, patients have to wait a long time. And our surgeons have said, don't do that. just get us the best heart and we'll rebuild the pulmonary arteries with a pericardial patch. So, we've done this for years, and I will tell you that there's even been books that have published this saying that, wait times are increased because we need non-lung donors to enable vascular reconstruction in these recipients. And I will show you that I was the person that wrote this in a book chapter. And Mike Diamond, who was one of our fellows, said, are we really needing to do this? And the answer is no. There's no, there's no benefit in outcomes in doing this. The patients have longer wait times, but there's no survival benefit. So we've stopped trying to wait on just a combined, to waiting on having the entire pulmonary artery tree. The fifth myth was that this, when along my pathway, there was in 2018, we changed the UNOS listing criteria, and there was this outcry from congenital specialists around the country. This is just not fair because you've put all of our congenitals in status 4, and then except for the VAD with MCS out of the hospital, which is a little bit like seeing a unicorn. So everybody was all up in arms that, oh, it's going to be terrible for our patients. And what Ari Cedars showed with Katya was that this actually wasn't even true. So our patients, there's been no, it's actually improved waitlist time for patients, and it hasn't worsened outcomes. We took this one extra step, and Anik at Raleigh, who's one of my partners now, who was a fellow here, what we found is that we're just writing a lot more exceptions. So part of this came from talking to many of you know Joe Rogers. I know Mandar, you know him. So Joe was sort of instrumental in this change in UNOS. And when I talked to him about how are we going to get these congenitals through the process, and he said, look, that's what the exception pathway is for. He was like, to be perfectly honest, we don't understand these patients. So what we're going to do is we're going to count on you to explain to us how high risk these patients are. You put them in 4, but you figure out how to get them to where they need to go. And this is exactly what's happened. Anik showed this nicely, is that we've had a significant increase in the number of patients that are listed with exceptions. So for instance, what this means is our Fontans that come in the hospital, right? The Fontans, you would say, okay, they're status 4. When we bring them in the hospital and then we have to put them on inotropes or dopamine and they need a heart liver and they're sensitized, I will write an exception and ask for them to be a status 2. And I feel pretty comfortable with saying that I think that patient is at very high risk for dying if they're not transplanted. And I think it's equivalent to a fresh sternotomy that's on a balloon pump. For the most part, people don't argue with us, and we don't argue with other people for the idea of you're not trying to game the system. What we're doing is we're proving to other people why we think these patients are high risk. The next thing that we found was, there's also this idea that, well, these congenitals are so complicated and they're highly sensitized, so there's no hearts, we're never going to get hearts. And I would say that that's not true. You just have to use all of the tools that we have for everybody else for our congenital patients. This was Kelly Schlendorf and Joanne Lindenfeld were some of the first that started doing hepatitis C here at Vanderbilt. And we started doing it right off the bat in our congenital patients. We didn't really know how it was going to impact them. We just said they don't really have any other options. We did it in a patient who was, this was Piper. She was the first time we had done a heart liver that was a Hep C donor. And so we took that and we combined our data with the group at Duke, and we've had about 11 patients. This is a little bit older now, but we've done a number of cases of congenitals that are either hepatitis C, or we've used OCS, or we've used DCD hearts. So we're pushing to do more of the invasive is probably not the right word, the more aggressive and newer technology stuff in the congenital patients as well. And this is Piper now about 6 years out. I show you this too because a lot of these patients have been awesome in terms of getting behind the whole transplant process and trying to get patients to register to be donors. The seventh myth I'll tell you about is that we even pretend to understand what to do with Fontans. And this is really problematic, and we don't really know how to manage these patients. When I came from Penn, the method at Penn was any patient that was a single ventricle patient that had at least stage 3 bridging fibrosis or fibrosis or cirrhosis got a combined heart liver. We thought that was right. What the kids, the pediatric centers, they think that nobody needs a liver transplant, and they will argue that the liver gets better. This data, much like our data at Penn was flawed, this data is also flawed because what you'll see is that, 7 of these patients successfully underwent heart transplant that had cirrhosis, but this was not, only 2 of these had biopsy proven cirrhosis, and throughout the rest of these patients, there's scattered cirrhosis. So I don't think you can say that either. I think the answer is somewhere based in this study where we've seen a signal that a number of these patients do better with a heart liver, but we don't know that that holds for everybody. I will tell you that some of this data, even that we were involved in Penn, like Matt Lewis has done an amazing job at Columbia trying to collaborate with all these different centers. But part of the problem is, too, in this data is that you have big centers like Penn that are saying that the heart livers are in this data and those patients have done well. What happens if we do a heart liver in someone that doesn't need a liver? If they do well, is it the liver or is it that they were a better specimen to move forward with transplant? So I would just say that we don't really know, and it has to be a collaborative process in order to transplant these patients. And the last myth I will tell you about is this has become a newer fascination of mine, is that Mayo Clinic has published about doing the heart after a liver transplant, and there's this idea that the liver soaks up all the antibodies and the patients don't reject. So they published this paper where they looked at heart after liver, and they gave these patients eculizumab, they did Plex, ATG, and they pretty much wiped out their immune system and then said that the patients don't reject and the liver protects these patients in highly sensitized patients. For those of you that do transplant, the 2 questions you're going to ask, though, is how highly sensitized were they really? And at the end of the day, centers look at things differently. Based on our criteria, the patients that were in this study weren't that highly sensitized. The other thing is that most centers don't look for antibody-mediated rejection early on. We've started to do that more because we're transplanting a lot of highly sensitized patients. What I will show you is that Shook, who's now at Atrium in Charlotte, looked at our data here. We've had a number of our heart livers that reject. Now, I'm not telling you that the liver doesn't help, but it's not, a heart liver doesn't mean you can walk away and pretend that patients have no evidence of rejection. The other thing to keep in mind is, if you look at the original Mayo study, and even in our study, when they reject, we treat them heavily with immunosuppression. And this is Camille Slomka, who was one of our patients who had PTLD within 1 year because we absolutely crushed his immune system. He's doing well now, but I just caution everyone to say, there's no free lunch in this game of heart liver. And as we sort of move towards wrapping up, I like to talk about this thing that I learned from Tim Tebow, who's one of my favorite people of all time. Not because I'm a Florida fan, but because of what he's done for the Down syndrome community and also for congenital heart community. But he talks about this idea of success versus significance, which I think is what Curley was talking about in City Slickers when he said the key to life is one thing. And I think a lot of what we do, we think about data and stats, but don't really consider the significance of what we're doing. So I want to just show you some of the stats and some of the data. As I told you, we had done 2 of these patients with congenital heart disease before I got here. And since that time, we've done 65. Well, actually, we did another one last night. So we've done 66 patients have been transplanted with congenital heart disease. And I'll show you the variety of different lesions. You'll see that most of our referrals are in single ventricle patients. These left-sided lesions, this is the Shone's group that's unfortunately growing fairly quickly for us as well. The other thing is, how do you measure success in terms of research? And I think, you can look at, oh, okay, how many manuscripts do you have on your CV sort of thing. But I think the way we've looked at research here, and I think Joanne Lindenfeld was 100% right, and she gets credit for all of this, is that we've been focused on provocative and argumentative topics that will hopefully change the way we take care of patients. And it's done two other things. It's allowed us to easily collaborate with a bunch of different centers outside of our institution, also collaborate within our institution. And it's forced the residents and fellows to get involved. And a number of our heart failure fellows have gotten involved in publishing and looking at data. And what that's actually done is a number of these people who now have gone to their center have now been dubbed the person that will take care of these failing congenitals, whether they like it or not. But I'll spend a little more time though telling you about the significance and tell you some patient stories, because I think we all have them. And I don't think we oftentimes pay enough attention to the impact we're all having on these patients. And sometimes it's the ability to take a breather that's really nice. I was Liz Barnett, who I told you, her goal was just to do a little bit of hiking. And this was her. They went hiking out west. And this is another Fontan. This is Jen Rice, who was a Fontan heart liver she's now back to work. She's a pediatric cardiac ICU nurse up in DC. This is Mr. Peterson. And, you talk about the significance that these patients have on us. He was a 50-year-old who, for reasons I don't understand, did really well with a heart alone. His liver was completely fine. And we don't completely understand why that is, because most of the time, by the time they get to 50, their livers are shot. So we're looking at that. The other thing is, because of him, it's sort of some of the patients have, led us down a research pathway. He was someone who his kidneys failed after transplant, was on dialysis for a year, and just got a kidney transplant, is doing fantastic. And so we're seeing a number of these patients that if we have to bring them back for kidney transplant, they end up doing really, really well. This is Destiny, who also led us to another, what I think is a cool research idea. This is her you guys probably don't know him, but this is Struggle Jennings. So Struggle is the grandson of Waylon Jennings, so famous country singers. We transplanted Struggle's uncle, but this young woman, Destiny, absolutely loves Struggle Jennings. So what we're lucky in Nashville, we have people all around that will come visit the patients, and it's amazing. You could do anything you want for them. You transplant them, and they're appreciative, and then they get to meet their country music celebrity, and they go absolutely nuts. So Struggle came to meet her, and it was amazing to see how he really just changed her whole outlook within a 20-minute meeting. But the thing that we learned about Destiny that was really interesting, we're going to start to look at this, is she's young, she's in her 20s, and she has some level of developmental delay, but we also always thought that she just wasn't functioning very well. We would talk to her and she's sort of out in left field. And we were concerned about her ability to manage transplant afterward. Could she take her meds? Could she follow instructions? Whatever. After transplant, she's a completely different kid. And I think some of this has to do with the fact that no matter what their cardiac output is, there is something about the Fontan brain is not getting appropriate amount of oxygen. And we're going to start to look at mental status and testing them for various levels of intellect before and after to see if it makes a difference, because I think it absolutely does. I take the worst selfies, but this is Jason Rappaport, who was a Shone's patient who was in the hospital for almost a year. Everything went wrong with him, including he even had parathyroid disease, which is something I'd never seen before. But this was a patient who had come to us where we first met him. He was doing poorly. We put him on goal-directed medical therapy, did significantly better for about a 3 or 4 year period. And then as he started to fall, we transplanted. This was a woman who was referred to us from a center in DC where we had collaborated with them for a number of years on different studies. And then this was our most recent patient, Miss Mann, who was referred to us from Alabama. The amazing part about her that has sort of changed the way we look at these patients is when she first came to see us, she was about 85 pounds. Um, and our surgeons thought she was quite frail. We put her through all sorts of frailty testing, and it turns out she was just thin and sick, but never met any frailty criteria. We transplanted her, and she was the first heart liver we transplanted that did not even go to inpatient rehab. She went to local housing, is completing outpatient rehab, and is now back. She was working as a cashier for years because she had no energy, where she would do like 2 hours every other day. She's now doing 7 hours at a time. So I think she's actually going to start doing something else, to be perfectly honest. And she would like everybody to know that she is up to 93 pounds and she's on her way to break 100. This was Joe Idle, who we transplanted, who was a Down syndrome patient who had been turned down at a number of different centers, and I think in large part because he was Down syndrome. And so we felt pretty strongly about not holding that against him. He underwent a combined heart liver and has done well. Because of Joe, he got connected with Mr. Stride, who was a patient that was turned down at his same center that turned him down. They said, come to Vanderbilt and let's see if we can transplant you. So we've now transplanted Mr. Stride also, who's now 4 years out and getting to spend a humongous amount of time with his family. And Joe likes when I show these pictures. Joe's got a girlfriend now, so he's a styling dude. And then the last thing just to tell you about is the bonds that have been made between our patients is really fantastic. I've shown you now all these patients. This is Liz, who was hiking, Rafi, who got engaged, Camille, who had cancer, is now doing significantly better, and Jen, who's the nurse. These patients all met because they all got transplanted right around the same time when they were in the hospital all together. They've built this network where they oftentimes stay with Rafi or Camille when they're here, and they've even formed this network where they're taking care of other patients and other congenital patients when they come into town. And I just think it's really cool what they've built. There's no HIPAA when you deal with congenital patients here at Vanderbilt because the patients all talk to each other. So I have said things like, well, I heard, Camille is rejecting. I'm like, I can't talk to you about that. That's like, all right, that's fine. I'll just call him. But Jen, who is really funny and told me she has a potty mouth, she said that they all met at Camp Menachem in 2021. And you can read for yourself how they defined it. So I will conclude with saying that the keys to changing this paradigm is that we've got to get these patients earlier and we've got to treat them together as a team, both within our hospitals and with other hospitals together. We really do have to stop just saying things and start demanding data, or we can be taking some chances. So if there isn't data, but we think we can make a good judgment as a team that we can try something in these patients, we should be doing it. And then for all of us, I think sometimes it's necessary to just stop and smell the roses because, medicine is not an easy specialty, and sometimes we're in the grind of it. But when you stop and think about the patients that we've impacted and the stories that they get to tell, it really is pretty significant. So I will end now, and I'm happy to take any questions or comments that you may have.
Thank you, Dr. Menachem. It's such inspiring to see, the growing number of congenital patients getting transplant. So we'll now move to questions. Feel free to either raise your hand